Hi everyone, it's Steve Field from the Prime Safety Department. We're very fortunate today. We've got Dr. Abraham from Trinity Health with us. I don't think there's a busier man on our campus right now than Dr. Abraham. He was busy before, keeping us all healthy, physicals, return to work, all sorts of issues, and then we've added in COVID-19. But Dr. Abraham did break away from downstairs for a few minutes, and we're going to run through some information today that I hope you find useful. Some of it we've talked about before. We do want to spend a little time talking about COVID-19, where we stand, quarantining, how that works, the symptoms, and then I think we're going to get into a couple of general questions about medical issues that we have, how the doctor determines how long your physical is good for, some of the more common disqualifiers and maybe ways you can work around those, the impact of different medications on you being qualified, just things that we get on a routine basis in the safety department. So we're going to get started, and I'll say, Dr. Abraham, thanks for being with us.
No problem. Happy to be here.
You know, let's start with, of course, COVID-19. It's on everyone's mind. We're all sick of it. We're tired. It doesn't seem like we're gaining any traction. We're still primarily working from home. We're quarantining folks. We're having to quarantine drivers. Maybe an update on where you think, big picture, we stand really as a country with COVID-19 right now.
Sure. As most of you know, and you've all heard on the news, COVID-19 continues to spread. We have seen some drops in numbers across the states over the last week or so. But I do believe we're in a little bit of a lull before we get another spike here. We've seen colleges and schools open this past week, and as we've seen in previous trends, it seems like about 3 to 4 weeks after something major happens, take for example Memorial Day, 4th of July, all these events typically follow with a spike in numbers about 3 to 4 weeks afterwards, which becomes a natural course of the disease and how it spreads to others around us. With that being said, hopefully we'll either continue to see a greater number of folks that become infected and contribute to what we call herd immunity, which is where we see 70% of the population be infected. And hopefully as the year ends and the next year begins, we'll see the emergence of a vaccination that is safe and effective. The treatments out there are still pretty questionable. Most of it becomes supportive care, as most people end up getting over the illness without a whole lot of issue. On the other hand, you'll have some folks that have a more severe illness that results in hospitalization and sometimes death. So, and that's the biggest thing we are concerned about here is the loss of life with COVID and the unpredictability of who does end up having a severe case of it. There doesn't seem to be a whole lot of rhyme or reason as to which people tend to get hit worse or which people tend to be infected. We've seen spouses get infected, whereas the rest of the household doesn't get affected. For all intents and purposes, all should have tested positive, but again, we're finding more and more out about COVID as we go along. So it's a very fluid situation. We're constantly learning more and more, and we're having to adapt and change our procedures and protocols as we go along.
You brought up the vaccine. I think a lot of us are thinking that may be the end goal, the vaccine, which would allow us maybe to travel more freely, open up international borders again, cruises. The vaccine, is that something we'll see probably not this year? What are your thoughts on that, Doctor?
Speaking frankly, I think that's somewhat of a loaded question because I think there's a lot of speculation as to politics that goes into that. A lot of media out there indicating we'll see a vaccine potentially by election time, whereas some say, no, we're looking at the first of the year. Either way, I think we'll be seeing it towards the end of the year as we go along, and there are several companies coming up with a vaccine, and they have different methodologies or ways of action that the vaccine will contribute immunity or at least decrease infectiousness to the COVID-19 virus. So, in my opinion, I think we'll probably see it towards the first of the year, and we want them to take their time with the vaccine and make sure, one, it is effective, and two, it is safe for those that are being administered it.
Now, I had read somewhere that talked about maybe this vaccine becoming like a flu shot, that we might need it every year. Is there any validity to that, or am I off base? Or
no, and you're pretty spot on there. That's a good question, and I do suspect it'll be much like the flu vaccine that we see. With influenza, we see numerous different strains come through, and each year they have to try and educate a guess and figure out what vaccine or what strain we need to be treating for the coming flu season. And I suspect we'll see something similar with COVID. There's a lot of talk about immunity and whether people get long-term immunity once they've been infected, once they've had the vaccine. You want to remember that COVID is a coronavirus, and about 15% of 15 and 20% of your colds that we get throughout the year are a type of coronavirus. They're not COVID-19, and that's why we call it novel, or the new COVID. But we find that people that have the cold will tend to experience repeat episodes of suffering from cold viruses, and we don't necessarily get an immunization for the cold because it's usually a mild disease and we usually get over it. But that doesn't mean we don't get infected again. Once you do get infected with a virus, you tend to build up antibodies, not only to attack the current virus, but also what we call memory cells, or cells that have the memory of the blueprints in order to create more antibodies. So even though the level of antibodies in our system may decrease as time goes on, we still have the blueprints in our system to recreate the antibodies, so it is no longer novel for us. And by way of that, we hope that we'll see decreased rates of transmission, decreased incidence of real severe disease. We're able to fight it off a lot easier, and we'll see more asymptomatic cases or real mild cases. We recently heard about a possible reinfection case out of Hong Kong, and just to clear up a little bit of the confusion on that, I know the news have been reporting that the gentleman had been infected in March and then again in August. In March, just to give you a few of the facts on it, in March he was actually symptomatic and was infected, and he tested positive. Since then he had recovered. In August when he tested, it was more of a routine test as he was coming off a flight. So he was asymptomatic and he happened to be positive. I know the initial report said he was reinfected. However, when they did some more digging, they found that his infection in August was different than the one in March because the virus had mutated, and it was somewhat of a slightly different strain. So, again, in August he was asymptomatic, which would make me think that he probably has antibodies in the system to help minimize any kind of effect that new strain would have caused him upon being infected.
So it sounds like there is some hope that will build up that herd immunity, and over time, the
I suspect so.
situation won't be quite as bad as it is now.
Correct.
Let's take a step back just for a minute, Doctor, and talk about, for our drivers out on the road, what they should be looking for. Obviously, every time you sneeze, you can't have a COVID-19 test. I've heard different things that you said, potentially the loss of taste or smell, severe headaches. If you had to list maybe the 5 most common characteristics of someone that has developed COVID-19, can you kind of go over those, and then what the protocol would be if a driver is out on the road? I got 4 out of 5 of those. What should I do now?
You bet. So some of the more common symptoms we see, and I'll tell you that depends a little and that varies a little bit, I believe, based on the strain that you actually can track. And if you ever get a chance, you should, if you Google COVID genetic map, I want to say the source is NextGen or something like that. Don't quote me on the source of that, but you'll see a genetic projection of COVID from when it originated to all the various strains that they've been able to catalog since then. And all these different strains have different mutations in them. So back to the original question, the difference of symptoms. In this area, I feel like we've seen more incidents of loss of sense of smell and taste. We haven't seen a whole lot in the way of fever being one of the main symptoms, but other areas indicate that as more of the primary symptom that they're seeing. So things we look for: fever, cough, shortness of breath, loss of sense of smell or taste, We've seen diarrhea as a symptom as well. And again, you want to remember when you look at these symptoms, is there a cause and effect? Did you eat something bad, get diarrhea? Do you have some other issue going on that might be causing some of these symptoms? So you really want to, look at these in the whole picture. Obviously, allergy season is here. Ragweed's hitting high, and even with that, though, some of these folks that are just complaining of allergy symptoms end up being positive for COVID. We've already had a couple of those cases come through our terminal where they felt like it was just allergies and then they'd be COVID positive. So, even though they are common symptoms, we want to make sure we're not dismissing them, because we do want to make sure we are identifying those that are infected and taking proper measures to help contain them.
It seems like the respiratory system is a common area, as you were mentioning that, because I've read that some of the worst cases, they end up on ventilators. It seems like they really have difficulty breathing. Maybe that is a symptom that, for someone that's relatively healthy, all of a sudden they just can't catch their breath.
Exactly. So, things are abrupt and a change from what the norm would be for you, or what you wouldn't think would be a normal symptom for you. Those are kind of issues you want to watch for. When you have something that is normal one day and all of a sudden you're acutely having shortness of breath, or some chest pain, or some issues with sense of smell or taste, for that.
I think, we started this in the middle of March. We've talked before. You had called Robert. We were traveling on an insurance visit. That was March 12th. I still remember the date. And you've talked about where we've had certain flare-ups. And the thing that popped in my mind is Memorial Day, 4th of July, returning to school. It seems like crowds are a big factor in this. And if someone, it's hard. We try to wear our masks all the time. We try to sanitize our hands, wash our hands, keep them away from our face. But crowd seems to be an issue that maybe we need to work a little harder and do whatever we can to avoid crowds. And
that's pretty spot on, Steve. And it's a good observation. When we have these gatherings, that's where we tend to see things spread. Whether it's at a crowded restaurant, a bar. Look at college campuses. How many colleges already closed within the first week of having classes? Look at the fraternity, sorority houses where they've got big outbreaks happening. But again, these big group events where people get together in a closed environment, especially families. Once we get around our families, we tend to be a little more lax. We figure, we're all safe. But you got to remember, there are people that are going to be asymptomatic and still spread it, and then they thereby pass it to an elderly relative, and that's where we have issues. There's ways to do things smartly. A lot of times, gathering outdoors with enough ample distance between you, and enough, circulation. Obviously, not in a confined space, but open parks.
We do really well in the truck. We do well with the shippers and the receivers at the terminal, but we're just human beings, and we love that contact. And we get home, and maybe we drop our guard a little bit.
Exactly. And we get home, and our family members, may have been. We can't monitor it, and we can't control everything as we go along. So, as we get home, off on home time, our spouse, our kids have been doing their own thing, and may not be as diligent as we have been, and then we end up with a situation where we get these positive cases as a result out of home time.
I think we're going to kind of move on. I'm just going to kind of summarize just for a minute on the COVID-19 situation. First of all, I do want to thank all our drivers for your participation in all the protocols that we've set up, and to reach the point sometimes even that we ask you not to come on to the terminal. We work something out where we can get your trailer fixed or swap out your load without you coming on to the yard. I think your dealings with the shippers and the receivers have all been just phenomenal. We certainly had some positive cases, but overall, when you look in its entirety, the number of places that all of you go every single day, and we've been doing this for 5 months, you've really done what's necessary to keep our company running. And when you compare us to other carriers out there, no one is doing the job that you're doing right now. So I do want to thank you for that. And as Dr. Abraham has said, we're still in the learning phase of this. We have a lot more to go. So please don't drop your guard. And I know it's so easy, even for us, we have it made, working in the terminal here. Either we go home every night, or a good percentage of our associates are already home because they basically don't leave their home. They're working from home, and we're all tired of it, as you are, but we need to keep our guard up. We need to keep doing the right things. We've talked about those. I won't beat that to death, but please, particularly on your home time, please try to stay as diligent as you can. No one deserves that home time more than a driver that's been out on the road, but I don't want to see anyone get sick. I know you don't want to get sick or infect your family. So hopefully that's helped you some with a little bit of COVID-19 on where we stand now. I am going to take advantage of the doctor being with us today and talk about a couple of different topics that come up quite often. And I think maybe the first one we'll go to, Dr. Abraham, is when someone is hospitalized or has a medical issue. They've got a good DOT physical, but maybe we'll just assume maybe they were dizzy or something, or passed out. And my staff and your staff go through a lot of these, exchanging information. What are you looking for when a driver has a health episode to know that he's clear to return to driving?
A couple things we look at. One, we look at the diagnosis, or what the end diagnosis was after the hospital staff has evaluated you and getting ready to discharge you. We also look at what medications they put you on, because most physicians out there are not familiar with FMCSA guidelines, and especially prime guidelines for that matter. And obviously some of these medications can be sedating. So truck diving is a very safety sensitive situation. We've got this 80,000-pound truck behind us, and we're on the road with the general public, and we want to make sure none of these medications or conditions could potentially impair you and result in an accident and a fatality. So we do look at the diagnosis to make sure it's not a diagnosis that raises concern for the FMCSA. But we also look at the medications that you're prescribed upon discharge. And once we know those things, we can always suggest what should be done differently, or what medications need to be discontinued and possibly tried with something else, just in order to get you back on the road. Our goal is not to keep you out. We want to get you back on the road driving, but we want to get you out there safely.
Dr. Abraham said something that I was going to say, he beat me to the punch there, and that is our goal is to get you back on the road. But of course, it has to be done safely. We can't have you out on the road if, I'll use that example of maybe you got lightheaded or fainted. We need to make sure that issue is resolved. If there's medication involved, we want Trinity and Dr. Abraham to say that that's not going to cause something else, drowsiness or something else that may impact your driving. So when you are either hospitalized or have a medical issue, make sure you get with the safety department. We'll coordinate with Dr. Abraham's office, and we'll do that just as quick as we can. We all want to get you back on the road, but we need to make sure it's safe, both for the motoring public and for you. Another question we had that a driver sent in, and we'll just kind of keep switching gears here, is sleep apnea. And what our protocol, of course, is that, and correct me if I'm wrong, you don't diagnose sleep apnea, but rather you look at the driver and say, maybe there's a good chance they have sleep apnea. So I guess my question is, what do you look at before you say, I'm going to refer you to a sleep study to determine whether in fact you have sleep apnea or not? And we know some sleep studies result in a negative, which is great, but the vast majority are positive. So my question is, what are you looking for? I know it's more than weight, but what do you look for when you refer someone for a sleep study?
Steve, to answer your question about sleep apnea, it is a multifactorial decision that we make. You're right, one of the criteria we do look at is weight. We picked a BMI of 39, and we chose that back when we initiated our sleep program. And the reason for that is because at that time, FMCSA was just starting to look at sleep apnea as a potential issue. And we looked and researched and felt that the FMCSA was probably going to come in with a lower BMI than what we were setting at 39. So we didn't want to be over aggressive with it, but we still want to be safe. So thereby we picked 39. We figured that the FMCSA would go with something like 35 or 31, as some carriers had gone to out there. But that, that's where the 39 BMI came from. We were being conservative, but yet safe. The other aspects that we look at are the airway. A lot of times I'll have folks that have maybe a BMI of 20, but their airway is so narrow that they can't get enough oxygen down into their lungs when they sleep at night. And you want to remember that sleep apnea is not just an issue of snoring. It's basically an issue of not getting oxygen into the system at night when you sleep. So if you think about it, when you go on 8 hours a night, every night with a lower than optimal oxygen level, your organs start to suffer. Your organs need oxygen 24/7. So if all of a sudden you cut out 8 hours of the day and your brain and your heart don't get the oxygen they need, it starts to put them at risk. It puts you at risk for heart attacks, strokes, starts to affect your hormones, can start to throw off testosterone levels, throw off cortisol levels. As the cortisol levels go out, it tends to make you more prone to gain diabetes. Cortisol also makes you more prone to gaining weight. It makes it really hard to lose weight, which then actually starts to propagate the issue even more. So as we put on more weight, it does make us more likely to get sleep apnea. As we put on more weight, we start to convert more of the testosterone to estrogen, which results in lower testosterone levels. And the testosterone helps keep the muscles that are in our airway. When we're younger, testosterone keeps our muscles nice and tight, including the muscles in your airway. So as we get older, as testosterone converts to estrogen, we start to lose that. So the muscles that open the airway start to get more lax, and thereby end up resulting in lower oxygen levels getting into the system when you sleep at night. So when that happens, like I said, it starts the whole sleep apnea cycle and starts getting worse at that point. And you know, I've seen folks that have had a BMI of 60 that have not had sleep apnea. And a lot of times it's all across the board, but for the most part, based on criteria, the airway, the neck size, the BMI, if people have other conditions such as diabetes, blood pressure, if they have multiple conditions, they tend to be more likely to have sleep apnea as well. So there are different things we look at in the whole picture as far as determining whether somebody should be screened for sleep apnea. Again, we're not diagnosing it, we're just indicating it's probably worth checking out. Much like we would, you know, if we're questioning, you know, potential heart issues, we're going to send you for a stress test. We're not necessarily going to say, oh, you've had a heart attack. We're going to do diagnostics and testing. So, and that's where Cardinal Sleep comes into play, and they've done a great job as far as the sleep studies and the monitoring program.
You know, we're very fortunate to have Cardinal Sleep kind of working in conjunction with Trinity Health and Dr. Abraham. And I do want to dispel a rumor, and I don't think it's too widespread, but our goal is not to send people for a sleep study to generate revenue. We would be ecstatic if Dr. Abraham never had to send another driver to a sleep study. But we all have health issues, and a lot of our drivers fit the criteria that most likely have sleep apnea, and it can be a serious health condition for you. And we really do this for a couple of reasons. One is for your health, and the second one is we know a healthy driver is not only a safer driver, but has a tendency to stay with us longer if they're healthy. So there is no hidden agenda with our sleep program other than trying to keep drivers as healthy as possible, because it's important. It's important to you, and it's also important to us as a company. I've got a question, kind of a two-part question, Doctor, and I remember we talked about this at a safety meeting once. If a driver has established a relationship with Trinity, and nobody has to use Trinity, you'll get your initial physical here if you're going through Springfield just because you're here, but if you have a family doctor, you're welcome to use that for other health issues. But I remember the question was, can I call in and have you call a prescription in for me? And if I remember right, your answer was if they've already established a relationship with your office, that's possible. Could you go over that a little bit? Maybe what can be done if a driver has used your office for health care?
You bet. Once we've established a regular medical relationship with you, aside from a DOT physical, we can call prescriptions in for you if we need be, if something's happened, if you're across the road. A lot of times we hear about drivers coming in and they haven't seen their primary in a couple of months, and their primary care doctor won't call them in medication because they want them to come in. And again, and I used to be in private practice myself on the outside and had no clue what a truck driver did. And I would probably done the same. I'd say, oh, come on in so we can check you out and see it. But that's not practical for a driver. Drivers can't drop everything and come into a doctor's office to get seen. So we do have to accommodate and make do with what we can, and we utilize our patient portal system where patients send us messages. We utilize our after-hours call system. We're on call 24/7 essentially. The answering service pages us and forwards us the message and lets us address patient issues that way. We also utilize televideo visits. So, you know, if it's during normal work hours and you're on the road and you need an appointment with us, we can do that via video on the computer, and you can jump on your phone and do that with us. So we try to make it as easy as possible for you to access healthcare. It's probably one of the biggest things that drives me is being able to bring healthcare to a population that has such a hard time accessing it out there.
You know, we're fortunate here in Springfield. We have your office, and you know, we've talked about this in the past. Is there still any opportunity for Trinity to expand to Salt Lake City or Pittston or both, where our drivers would have the fantastic luxury we have here in Springfield of basically coming to the terminal while you're getting your truck worked on, you're getting a physical, kind of all-in-one shopping?
And that is the anticipation. We are, and we've been saying for a few years now that we're going to open up in Pennsylvania here, and you know, it's a matter of logistics and jumping through. Each state has different guidelines as to medical care, etc. And the goal is to eventually provide medical service in Pennsylvania as well as Salt Lake. As the Salt Lake construction comes to a close here, we you know, have been going through the designs and making sure that the clinic's all set. And as we're able to, we will get staff in both locations in order to provide the health care that drivers so desperately need.
Well, that would be really, really nice if we could have that out in Salt Lake. And I think that facility, that is one we're going to be able to grow for years out there. And we've built a massive facility out there, and we just basically need the drivers and the trucks, and with that comes, you know, everything that goes with that, to include the health care. So we're certainly looking forward to that. Another topic I want to talk to the doctor while we have him is, forever, for as long as I've been in trucking, if a driver had diabetes, there were certain opportunities for him, but all of them were difficult, and they almost all revolved around having to get an exemption from the FMCSA. That has changed recently, and it's really opened the door for a lot of drivers whose diabetes is well managed, that they don't need to go through all those hoops to get the exemption. And could you talk about that a little bit, Doctor? Someone gets diagnosed or has diabetes, how does that work with their diabetes doctor and yourself, and getting them a medical certificate?
Yeah. So with diabetes, and for a long time there's been a lot of stigma of diabetes and a lot of myths out there. A lot of times drivers think, oh, if I have diabetes, I can't drive. That is completely false. You can absolutely drive if you have diabetes. And frankly, we'd rather find out now if you have diabetes than 5 years down the road when it's uncontrolled. So I strongly encourage you to get checked every year for that. Diabetes is such a prevalent disease in the driver population. Initially, you know, we'll treat that with oral medications, and there are some injectable medicines that are not insulin that you can drive with without issue. Up till about a couple of years ago, insulin was a very difficult medication to drive on, and you had to jump through a lot of hoops, as Steve said, in order to get that passed and cleared. And to the point where it took probably a good 9 to 12 months in order to get back on the road. With the recent regulation that got put through, now drivers are able to drive quite a bit sooner. They have to obviously be stable on their insulin, so they're not having low sugar dropped, which can be just as dangerous as high sugar, because that can put you in a coma where you pass away and don't wake up. So again, we want to make sure that if you are on insulin, you're safe. There is a form that you can download from the FMCSA site. It's an insulin waiver form, and you take that to your provider and they'll fill out all the necessary information there, and you want to make sure you bring that to us during your physical, and as long as you have that, we can pass you without issue.
And that really is a big change. So, you know, we're fortunate that the FMCSA has listened. I think as medical techniques have changed, it's kind of opened the door for that. Now, we're going to probably wrap it up here, and you know, a couple of things. I always like to close by saying a few things. The first one I'm going to say is, you know, thanks for being here, Dr. Abraham. I know you're super busy. You know, we are so fortunate to have you here in our terminal. I can't imagine how we would have gotten through this, and we're not through it yet, but how we would have made it this far with COVID-19 without your guidance. You know, I've called you at 6 in the morning, 6 at night. It doesn't matter. You're always available for us. So, you know, we certainly appreciate that, and I don't know if we say thank you enough, but certainly thank you for all you've done for our company and keeping us going through this. You know, we talked a lot today. We talk about it in the driver meetings. We haven't had one for nearly 6 months. You'll hear it from Robert. You'll hear it from others. We want you to stay healthy. Your health is important. Drivers work far too hard and unfortunately die far too young in many cases. And a lot of that truly is preventable if you work on your health. And it is a sedentary profession where you do sit a lot. I know you're sleeping in the back of your truck. The meals are on the go. There's a lot of challenges, but we've seen a lot of improvement in the last 15 or 20 years, particularly at Prime with our health and fitness. We've got Matt Hancock now and Sarah Waterman that are both extremely anxious to help you. Take advantage of their services and do what you can, because we want you here for a long, long time, and even more importantly than that, your family wants you around for a long, long time. So, you know, I appreciate you listening in. I think next week we'll probably get all the department heads again. We haven't done that in several weeks, and we'll just get an update across the board on where we are with our long-term goal to be able to return to the safety meetings. But we can't do it till it's safe. That's truly a crowd. You can see we're in the cafeteria here today, and it's nearly empty, and that's just a product of COVID-19. And those of you that have been to our safety meetings know we normally fill the place up, and that's just not practical right now. So when we can, when it's safe, we'll return to the safety meetings. But until then, we'll just continue to put an informational video out each week for you. I do want to thank you for everything you're doing out there, for being safe, for taking care of America. America would not be what it is without truckers. So thank you for that, and we will see you again next week. Thank you, Dr. Abraham.
Thanks, Steve.